So we were talking about skeletal TB, which includes POTS TB. It accounts for 50% of all the TBs, musculoskeletal one. Remember, in the skeletal TB, the most commonly affected is thoracic, then lumbar, then sacral. Other joints are also involved. Uh, Clinical features include persistent back pain, and gibbous deformity, and neurological deficits and cold abscess. Skeletal TB MRI is the choice, which shows vertebral destruction, disc involvement, paravertebral abscess, spinal cord compression. If you look at the MRI, there is vertebral destruction. There is abscess formation in these structures. Treatment will include 12 months of ATT, and surgery will be involved in cases where there is progressive neurological deficit, spinal instability, deformity, large abscess, or failure of medical therapy. We can extend the treatment up till 18 months. In cases of abdominal TB, it can include any other organ. Peritoneum is the most common. Ileocecal region is the most common involvement. There will be mesenteric lymphadenitis, colon, and solid organ involvement. In cases, there can be chronic abdominal pain, weight loss, anorexia, abdominal distension, ascites, altered bowel habits, abdominal mass, and features of intestinal obstruction or perforation in cases of complicated diseases. The diagnosis would be imaging, which includes ultrasound or CCT, which will show us ascites, bowel wall thickening, and lymphadenopathy and peritoneal thickening. Ascitic fluid will be exudative lymphocytic predominant with ADF more than 33 to 40, and serum ascitic albumin gradient will be less than 1.1. And imaging like endoscopy and colonoscopy will help us in diagnosis with biopsy. So what we see here are the ulcers, then we see here are the polyps, here we see the strictures, complications. The treatment would be 6 months of ATT. If there is obstruction, perforation, bleeding, strictures or fistulae, then requirement for surgery comes. Like in cases of the CCT, there is thickening of the bowel, there is ascitic fluid, and there is stricture seen in the surgery laparoscopic image. So in cases of urogenital TB, kidneys are the most commonly affected. Ureter, urinary bladder followed. Dysuria, urinary frequency and urgency increases. Flank pain is present. Hematuria might be there. Sterile pyuria with negative urine culture. Urinary tract symptoms, scrotal swelling, and infertility or chronic pelvic pain in cases of females. What we see here in this diagram is an abscess. It's a TB abscess and can be diagnosed by histopathology. Complications of it will include hydronephrosis, ureteric strictures, calcification, and non-functioning kidney. In these cases, surgery might be useful, otherwise 6 months of ATT suffice. Cutaneous TB, it ranges into tuberculates and true cutaneous TB. Tuberculates are nothing but hypersensitivity reaction, whereas true cutaneous TB are a result of direct manifestation of the infection by the bacilli to the skin. So if it is a contiguous or an auto-inoculation, it is Crofilderma TB cutis orificialis. Hematogenous spreads include lupus vulgaris, miliary TB, metastatic tuberculous abscess, and from exogenous source, remember it is TB chancre. This is a case of lupus vulgaris. Treatment, it will be regional lymphadenopathy, sinus tract formation, nodule ulcer, varicose lesion, plaques, and non-healing skin ulcers will give a clue to TB. Diagnosis by skin biopsy and histopathology. Treatment includes 6 months of ATT. For ocular TB, remember it is the most common is uveitis, posterior uveitis, panuveitis, choroidal tuberculosis and tuberculoma. retinal vasculitis and neuritis, and other manifestations include optic neuritis. Diagnosis by fundus examination, which shows these tuberculomas in the choroidal region, or optical coherence tomography will help us in determining it. Thank you.